I'll introduce real quick our speaker for Grand Rounds today. It's Dr. Robert Seifert. I know him as Bob Seifert. He's the unit director and section medical director of hematopathology and processing facility director for the stem cell laboratory at the University of Florida and the medical center there. He directs the medical school course in microbiology and immunology, as well as general pathology for the dental school. He's been recognized with the Exemplary Teacher Award every year since 2020. And he's been a member of the College of Medicine Curriculum Committee since 2021. He's the co-chair of the Med School Admissions Committee. He served on a bunch of educational boards, including for state and national organizations like Society for Hematopathology and Florida Society Pathologist, which he's been really involved in. He was recognized in 2021 as one of ASCP's 40 under 40 and was recently inducted into the AOA Medical Honors Society. I can say firsthand that he's a fantastic educator. He taught me some heme path, and I hope I haven't forgotten all of it um, in the meantime. And he's worn many hats at the University of Florida in the medical pathology system there previously as well. So we're really happy he was able to join us even on somewhat short notice. And without further ado, take it away, Dr. Seifert.
Hey, good morning, everybody. Thank you, Garrett, for that really kind introduction. So today I'm actually not going to so much be talking about heme path as about another hot topic in our discipline of pathology in general, which is AI and kind of how it's going to impact us. Specifically, I want to address how to critique journal articles about AI because I think that's a skill that requires some knowledge, a little bit of what's going on under the hood, so to speak. And I'm hoping I can speak to those components today. And so I like to begin with a quote from The Lord of the Rings. I try to do that as often as possible in my lectures. And so this is even the wise cannot see all ends, and I'll show you what I mean by this in a second here. Um, Here are our learning objectives. I really hope by the end of this, you're able to think critically about journal articles and about how to integrate different AI tools in your daily practice, or at least consider what impact it might have. Here are my disclosures. In addition to my financial disclosures, I should say I don't have any formal background in computer science. Um, and so I may say some things that, like, if you do, it might be a little bit off or oversimplified. But I actually think, in some sense, it makes me more qualified to give this talk because I know I'm kind of coming from the same ground as probably most of you. I didn't use AI to produce this lecture, and even though I said there's not going to be much heme path, there's going to be a little bit of flow cytometry in this presentation, just because I can't help myself as a hematopathologist. So, I mean, you look around, everyone's talking about AI. There's people that are saying it's going to change everything for the good. There's kind of the opposite, the anti-hype, that's it's going to destroy the world. I don't know exactly where I stand. And then if you look, if you look within our own discipline, there's new articles all the time using AI for different diagnostic or different parts of our workflow in pathology. I understand that you all recently adopted, I think some are in the planning on adopting something called Halo AI, and we're looking at stuff too. So I think it's very relevant. When I see stuff like this, pop up, the little Copilot icon pop up on my screen. I'm of the age that I remember when this little guy used to pop up, and I feel kind of similar about it. So just to give you some sense of where I'm coming from. Um, I want to kind of outline where we are, right? Like, this is a disruptive technology, and medicine has experienced that before. The stethoscope changed how we do physical exams. Randomized control trials, and kind of modern statistics led to evidence-based medicine. The problem-oriented medical record, kind of standardizing that, led to the electronic medical record, for better or worse. Google happened, and we got Wikipedia and UpToDate, and it's debatable how useful some of those things are. And then I think a real uh, watershed moment is when Facebook came out. We thought, and Twitter and these kind of things, we thought it would um, democratize things. It would be the end to dictatorships and stuff like that around the world, and that hasn't really been the case, right? We sort of didn't predict that correctly, and especially I think the psychological harm that social media does to young people. And so my hot take on this is that we stink, especially more recently, at predicting the impact of disruptive technology. And so I think we need to be very careful how we think about AI and how we think about how we're going to use it in medicine. And so if you just go on to PubMed and search pathology and artificial intelligence, this is what you get. Obviously, more and more being published on it, especially since sort of the turning point where ChatGPT occurred around 2021. Um, and so where are we going today? I'm going to talk mostly about machine learning classifiers. I'll define what that is in a moment. I'm not going to talk too much about ChatGPT, although there is a little bit at the end that I want to share that I think is very important. And why there was I published on this a little while back within my own discipline. So what is a classifier, right? So we've probably seen these before in medicine pre-AI, right? So if you have like test result A and B and you have healthy and diseased patients, you could use like a logistic regression or a linear regression or different kinds of models to predict the probability that given the results of test result A and B, you're either going to be on the healthy or the diseased side, right? That's existed for a long time. And it's kind of easy for us to look at. We're pretty good, us human beings, at looking at things in 2D and drawing conclusions. And this is a 2D plot using two variables, right? Test result A and test result B to predict whether or not a patient's going to be diseased or healthy. Well, what ChatGPT is it has 1.4 maybe trillion features, right? So dimensions, right? So 1.4 trillion of these. And it's occurring in not 2D space, but something like 16,000 D space, right? So think of, we can't even visualize what that looks like, which is why it's such a black box and such a mystery. And I hope through this lecture, I can demystify some of that. So how are ML machine learning classifiers made, right? So something you may have seen before is sort of the annotated slide, right? So we get a Ki-67 and the pathologist sits there and circles like this is a positive, this is a negative, and then the classifier trains on those annotations. There's a couple problems with this, although they're not necessarily deal breakers. One is that the expert needs to be correct. And there may be some unaccounted for confounders. There's some classic stories of AI in the world of radiology where in fact, the AI classifier was keying in on things like the initials on the X-ray or red stickers on the X-ray rather than the contents of the X-ray themselves in order to classify them as being benign or malignant, for example. Um, so a solution to this is deep learning, which is really just letting the classifier train itself. And this can be done in a supervised fashion where the data is still labeled. So we say like these are the positive slides, these are the benign slides. Or it could be done in an unsupervised manner where we just give the machine learning algorithm a whole host of data, 10,000 cases, and say, you just look at these and we'll get back to you. And in some sense, I actually think that's like training a resident or a fellow. 10,000 slides is probably about what a trainee needs to see to be competent in practice. So I think there's something to that, actually. If unsupervised, we're not really putting ground truth labels on it, like I mentioned. To do this successfully, you need large data sets. You really do need large data sets. You can't just use a couple hundred cases for this to work. So I want to talk, now that I've kind of given you an overview, I want to talk about how to actually build one of these classifiers. If you had an idea, how would you actually build one? And we're going to walk through that now. So the first question you should ask yourself is machine learning or is AI even the most appropriate tool? And I have here illustrate the Hans criteria for diffuse large B-cell lymphoma. And you need to ask yourself, can you tolerate mistakes or the kind of mistakes that AI could make? Is a rules-based approach like an algorithm, like here the Hans criteria, just as good? Would traditional statistical methods work just as well? And this is something that I think some people are missing now, actually. They're doing, they might do a traditional kind of study, and instead of using a multivariate regression or some basic statistics that have been around for a long time. They're using a machine learning classifier AI to generate statistics, and I don't think that's really the right fit. Um, and then you really need to consider the use case in pathology. Is it going to be some kind of screening tool for you? It's going to look at cases in advance and flag the malignants or possible malignant cases for you? Or is it an adjunct, like something that's sort of like Copilot, if you will, sitting next to you, helping you make a judgment? Um, the next step is to obtain big data, right? So you need a lot of cases in order for a deep learning algorithm to to extract generalizable features. Something that I haven't seen a lot of articles do is is use a data set that has a realistic balance of cases, right? So a balance of positive, malignant cases versus negative benign cases in a data set that actually mimics real life or the actual prevalence or incidence of a disease. I've not seen that done a whole lot. In fact, it's usually closer to 50-50. And I'm not sure that that's doing us any favors in making these classifiers. In some cases, I've seen uh, basically a variable weighting applied to this, so that like the benign cases might be overweight to try and mimic what actually happens. But again, I don't know that that is going to help a machine learning classifier work in real life, as we'll see in a minute. The next thing you need to do is prepare high quality data, and this is much easier said than done. So the data sets need to be free of errors. They need to be very consistent and uniformly formatted. This is a huge problem, right? Think of a database or something that you might have access to, and there's probably problems with data entry that you have. Like just look at your electronic healthcare. Like people don't consistently enter the data correctly. That's got to get fixed before you can apply a machine learning classifier. And this is usually the most tedious step. An old-fashioned kind of way at this point of looking at data is to do what's called dimensionality reduction. And in fact, many times when high quality data is being prepared, the data will be transformed a priori. In other words, we will take all of the data, a whole slide image, let's say, and reduce it into just a couple of vectors. And one way of doing that is the T-sign mechanism here. So I'm showing some flow cytometry plots, and I'm reducing those. There's basically 24 variables shown on the flow cytometry plots, and I'm reducing those to two. I can't interpret this, right? I don't really know what this means anymore after we've done this transformation. But this makes it easier for a machine learning algorithm to digest. And in fact, this for a machine learning algorithm to train on something like flow cytometry, where there's a lot more variables. Or whole slide image, for example, requires a lot more computing power. If you've done a transformation ahead of time, this could be run on a laptop, and that is a big reason why so many studies do this. It could be good, it could be useful to do this, but doing this wrong, doing this poorly, can lead to what's called overfitting, which I'll define in a minute here. And something to think about is, if you're using a machine learning algorithm to kind of substitute or be an adjunct to your own judgment, you have to consider also the way that you look at cases. I look at cases this way, right? I look at the 2D scatter plots, or I look at a slide under the microscope. I don't look at this. So just things to think about. So I mentioned overfitting. I actually think this is probably one of the most important concepts that you get. If you get anything out of my talk, it's that you understand what overfitting is, because I think it's very, very important when you are approaching machine learning algorithm articles, that you know what this is and you know what the signs of it are. So, this was the sort of logistic regression line that we got that I think just it passes the eyeball test, right? So these are the malignant cases, these are benign cases. This seems to more or less cut them in half, right? Overfitting is if the logistic regression line looked like this. If I was to, look at this sample that we developed this line for, it would probably show that there was amazing accuracy, 99.9% accuracy, really, really strong positive predictive value. But does this probably represent real life? Probably not. So we have overfit this line to the training data. So we're going to see some examples of this as we go through, and where a lot of journal articles are getting this wrong or touting this as reality. So just keep this in mind that it is possible when generating these machine learning algorithms that we overfit what the equation that comes out of this, the model that comes out of this, to the training data, such that it utterly fails once it meets real life, the unknowable future, the out of sample data that we feed into the model. The next step after you've done that is to select what are your optimization metrics. This is where you're picking a model, and you may have seen some of these talked about. There's a CNN, which is a convolutional neural network. That's probably one of the most talked about. There's some older things like random forest, XGBoost. We don't need to know for today, for purposes of our talk, like what these actually are. They're just different ways of processing the data and generating a AI model that can be used. The next step you need to do is configure the model's loss function. So as the model is training, and I'll have some slides on this in a minute, it decides how wrong it was each cycle of training, and then makes adjustments to all of those, millions, billions of parameters that it has. And one of the things historically that really drove AI forward is something called gradient boosting. It's a mathematical technique aimed at iteratively improving the model. And then you may see something talked about called hyperparameters. They're really like the training settings of a model. I think if you get to this point and you're trying to make a machine learning model, you need the help of an actual expert, someone with a background in this, and you shouldn't probably do it yourself. Okay, now we're going to get into the parts of training that are really important when you're reading the methods section of an article about machine learning. So say your data consists of a bunch of benign and malignant lymph node whole slide images. A typical way of training the model is to divide about 80% of those cases for training, and then 20% will be held out for validation. And this is not the same thing as an LDT, lab test validation. This is a model validation concept. So you see that term validation used in the literature. Some articles call this discovery and development. So just be aware there's some different terminology out there. And the idea is that we iteratively train on that 80% over and over again until we have a model that's satisfactory. And then we test it on that holdout 20%. But that is not prospective, right? We're still talking about in-sample, what is effectively in-sample data. So what does training look like? This is a schematic of a CNN, a convolutional neural network. And it seems a little bit opaque and a little bit weird and confusing, but it's not too bad. Basically, each of these nodes, right, takes what is initially input raw data and applies mathematical transformations to it, thousands of mathematical transformations to it. It's sometimes semi-random what it does. And then it takes that data and it tries to extract features, which are just variables that it could possibly use, and passes them on to the next node. And it usually passes them on to several other nodes. And these pass through multiple layers until they get to the end. And it says, I think the classification is benign. And if it's right, then it'll go back and look at what did it do right that was, that led it to being right. And it'll adjust the weights of these features that it's extracting appropriately. And then it'll iterate again. And it actually does this over and over again until it optimizes the output. And it's getting most of the cases in that 80% correct. And we call each of these cycles, you might see them, they're called an epoch, basically, is what each of these cycles through training is. Many journal articles stop here and publish this information and say, look, we generated a model and it's 99% accurate. And I think that proves nothing because it's very easy with these kind of techniques to optimize your model for exactly that piece of data that you submitted to it, and it won't survive the real world, basically. So the next step is called validation of a model, and that is, again, not an LDT validation. This is just a term used in the world of machine learning classifiers. And really what you're trying to do is prove that the model can achieve good out-of-sample results, specifically on that 20% that you held out. And typically that's what we're doing is we're testing it on that 20%. The problem is this is not truly prospective. It gets touted this way, and articles will sort of claim this is prospective, and it's not. It's really that same batch of data that you got initially. And so I don't think it will necessarily correlate with real life. Another problem that many articles in pathology especially have run into is that they have insufficient big data for appropriate training. They don't have access to 10,000 cases that they could use. And so they do something called k-fold cross-validation. And this technique shows up often enough that I think we need to stop and go through it, even though there's a little bit of math involved, but I think we really need to talk about what it is. And again, some articles wrongly stop here after validation and treat this validation as if it was a prospective trial. So be aware of that. So let's talk about k-fold cross-validation and what that means. So we said we took 80% of our data and trained the model on it and then saved 20% to sort of test it out. A technique to do this that will prevent us from overfitting is k-fold cross-validation. What that means is we split instead our big data into 5 parts. So that would be a 5-fold cross-validation. And we rotate through each of those parts and train the model 5 different times and test the model or validate the model 5 different times. So round 1, the first 4 quintiles are used for training, and that 5th quintile is used for validation. And we're going to do that over and over again until we get to round 5, where quintile 1, 2, 3, and 5 are used for training, and then the 4th one is held out for validation. And we merge all that information together to make a model and generate statistics of how well that model performed. There's some problems with that, although it does work better and is less prone to overfitting with a sufficiently small data set. But some problems with that are it's really hard to adjust the model if you're splitting the data up in that way. And you'll probably introduce bias if you attempt to, say, in round three, make adjustments to hyperparameters to get a better result. And the statistics will be spit out of this, as it were, when you're validating the model. We're going to talk a little bit about what are the appropriate statistics when evaluating a model. But I don't think the CV will be representative because of how we iterated through the same cases a multitude of times. Okay, so we've done that. We've trained, we've validated. Now you really need to prospectively test the model on data that it has not seen before, data that you did not collect, and really do it in real time, live. And this rarely happens, as we'll see. So test the model using new data points not present. Um, my own PubMed searches within pathology, there's really very, very few scoping articles on this, but my own just kind of search through pathology, I found one that was actually prospective. I found a few observational, so some like case control kind of studies. And there's only really one in Flow that's any good that just came out recently. Um, Most of them are out of a group in ARUP that's been putting them out for the few people on the call that might be interested in flow cytometry, but not really any prospective models. And then kind of looking out, like what's the rest of medicine doing, right? So as of 2021, only 4 of 130 FDA-approved medical devices that use an AI algorithm had prospective trials. I won't necessarily ding the FDA for this because they don't require that for everything. It depends on what the medical device is. But as of 2023, a major scoping article only found 86 prospective randomized controlled clinical trials using AI, and that's less than 1% of the AI literature. So that's a pretty astounding figure, basically. Whereas with other tools, other things, we would do this in medicine. We're not doing that with AI, and I think that's kind of shocking, actually. And then even I would actually say the figure is probably much less than 1% because the number of these articles still have questionable endpoints where it's just, did the AI beat the physician in diagnosis or in triaging a patient? And I don't know that that's useful, or at least it's not as useful as patient outcomes, right? That's usually what we look for when we look at randomized controlled clinical trials. How did the patient do? And so those are even fewer. And then you deploy the model, right? You do that, you're happy with the results, you deploy the model. And so here's a summary. So you should definitely ask, is machine learning the right tool? Get your big data, spend a lot of time preparing your big data, put a model together, train the model, validate the model, prospectively test the model, and then maybe you're good to go at that point. So these are the steps that need to be followed. I want to switch here and talk about how to take what we've learned and apply it to some of these articles that are out there in the literature. And I will give you fair warning. We're going to talk a little bit about statistics because I think we have to really get a good understanding of that. So that's our next topic. Okay. So again, I'm kind of taking from an article in Flow to get us started. But so much machine learning work in AP, we're talking about scan slides or hold slide images, right? Flow cytometry is kind of unique in that the data is already tabular, right? The data is in a format that's not too different from a spreadsheet. And so this article here aimed to build a classifier that can reliably separate CLL, which is very common lymphoma, from normal bloods. A pretty basic approach. And so, what does flow cytometry data look like? So here's just a plot of a kappa clone, right? So a lot of dots, right? All in kappa, not very many in lambda. Each of these dots represents one cell. And so we can actually find that cell in a data table, right, of the flow cytometry data. So there's that cell. It's got it's got some kappa and it doesn't have, or sorry, it's got some lambda expression. It doesn't have any kappa, right? So these are all numbers, and that we could potentially feed without much transformation into a machine learning classifier. So what did this article do? Well, they looked at 44 CLL cases and 53 bloods. That's a very small n, right? A very, very low number. And then the class balance is not right, right? There's the incidence of CLL, while it's pretty common, is still much less than about 50-50, which is what they were doing. For data processing, to enable them to run this basically on a laptop, they compressed each case to one row of data. That is, they took all of this all of this and put it into one long, long, long row of data, which is kind of strange, but it's an interesting way of transforming it anyway. It certainly isn't the way that I would be interpreting the data. And lost in the process is all of the labels. So I showed you that, okay, this has a lambda expression of such and such and a kappa expression of like not very much, right? That's lost in this. Um, so the first few hundred events were removed because they might be error, and then they captured only about 800 events, and that's not at all close to what we look at when we look at a flow cytometry test. And by events, I mean cells, basically, cells that are dots on the flow cytometry plot. So we're only looking at about 3.85% of what I would be looking at if I saw a case. So so far, what they've done does not seem to represent what a human being would do in looking at flow. But they don't really transform the data apart from compressing it down to one row. So I think that is kind of interesting. So what did other studies do? We did a review of a bunch of other flow cytometry studies. And I think the number of events or cells per tube varied from way below what we would normally do to about what we would normally do for a given case. Most of the time, the class balance was 50-50 benign and malignant, so not representative. And some of them duplicated positives or duplicated negatives to achieve a class balance, which is kind of strange. And again, you're asking the model to evaluate the same case multiple times. That's probably going to lead to overfitting. Most of the articles did some kind of a priori transformation of the raw data, like principal component analysis or cluster analysis, like I was showing. Again, you're helping the computer out. You're making it easier for the computer to make a model, but you're giving it data that a human being would not really be able to read. So I think that's kind of something to think about. This article, going back to the one we're talking about here, was trained on XGBoost and a CNN, and they did a tenfold cross-validation. Again, that's to compensate for their very low number of cases. Um, and so how do we interpret the results that spit out of this, right? So how do we know how accurate it is? So let's talk about the statistics that are resulted when we are testing out machine learning models. And this is what's going to be published in the literature. So accuracy, that is similar to what we think about already in the clinical lab as accuracy, right? The sum of the true results divided by the sum of all the results. Um, where you need to be cautious is there's some name alert, there's some wrong use of terminology in the AI literature, and that is what we call sensitivity. True positives divided by true positives plus false negatives. They call recall, which is interesting and actually comes from how search engines were developed about 20, 30 years ago. And another way of thinking of it is just the true positive rate. But you'll see these other terms, not sensitivity, used in the literature. You'll see things like recall and true positive rate. Even worse is what we call the positive predictive value, they call precision. And that has nothing to do with the precision that we think about in the clinical lab, right? Getting the same result over and over again. It's really not the same thing. What we're talking about here is positive predictive value. And then there's a number that you will see over and over again in the AI literature, which is the F1 score. And it's it's become, I mean, people obsess over these. It is a single numeric value that you can assign to a machine learning algorithm, right, to describe how good it is. And so there's a lot of questions that I can't answer about it, though, as we'll see. But I mean, people on, there are, message boards and places where people really debate like the ranking and the how different things perform based on just their F1 score. And I think that might be misplaced enthusiasm. What is the F1 score? It is the harmonic mean of the sensitivity and positive predictive value, or the recall and precision, as they'll describe in the article. We'll see what I mean by that in a second here. So, and there's a number that ranges from 0 to 1. And what it is two times the true positives divided by, again, two times the true positives plus the sum of the false positives and false negatives. So that's what they mean by harmonic mean. So one thing that, if you're looking at this equation that is notably absent, is the true negatives. So this assumes that the problem with this score is it assumes that the true positive is rare, despite anything about the class balance in the model. And really what that comes from, again, is this F1 score was really popularized when search engines like Google were first being developed in the late 90s. And you think about it, like what is rare? Your true positive is the thing you're looking for in a search engine, right? So a good way to score how well a search engine is performing is how well it's able to recall like what you're trying to find, like the website you're trying to search. So it comes historically from that. I think it's inappropriate for medicine to be using in most cases. It assumes that false negatives have the same importance or weight as false positives. That's something that might not be true depending on how you're going to use this algorithm. So that's why deciding how you're going to use this is so important to do upfront. Um, yeah, it's used extensively in the literature. Some alternatives that you'll see are the Cohen's kappa. That's used widely in the literature, especially comparing like multiple different pathologists looking at the same thing. I think it has some utility. It's very sensitive to class imbalances. I think a better measure is something that I hadn't heard of before I started reading about this, which is the Matthews correlation coefficient. And so this is a number that will range from -1 to +1, +1 being the best. It's actually very robust to a wide variety of class imbalances. So it doesn't care whether you've got a 50-50 class imbalance or an appropriate class imbalance. And a high score requires that both the majority of the positive cases and the majority of the negative cases were called correctly. So that sounds like something we want. And I think it's probably the best single number measure of how well a model is performing. It is very rarely used so far in the medical literature, but I would, if I was handed an article to peer review, I would ask them to calculate this because I think it's really important to give readers a better understanding of how well something is performing. So how did a whole bunch of flow cytometry studies in AI report their results, right? Most of them reported the accuracy. About half of them reported an F1 score. Our article that we're critiquing here showed an accuracy of 83.33 and an F1 score of 0.78. And there's techniques to look at. Well, most of these machine learning algorithms are kind of a black box, right? We don't really know what transformations and what the equation that it's using looks like. But you can ask it what features were the most important. And it said forward light scatter was one of the most important features, which if you're a practicing hematopathologist, that's kind of weird, right? Forward scatter tells us a little bit of information about the size of cells, but when we're talking about classifying B cells as either polyclonal or monoclonal, you'd think kappa or lambda would be pretty important for that, and it turns out it wasn't. So that makes a model not pass the sniff test, so to speak, where if it's using something that isn't realistic. Not that models can't discover new features and variables that we can't necessarily see, but it has to kind of come back and make sense. A sort of it has to have some level of importance to look closely at that. An 83% accuracy means it is wrong 16.67% of the time. And that's an interesting number to me because that's basically like one on a six-sided dice. So the number needed to misdiagnose, which I think anytime a machine learning article gives you the accuracy, you should calculate this value. It's very similar to the number needed to treat in medicine. The number needed to misdiagnose is how many cases do you have to see before you misdiagnose somebody? And so it's 1 divided by 1 minus the accuracy. And so that means every 6 patients, we will have 1 misdiagnosis. And so that's an important thing to look about because otherwise you'd look at 83% accuracy and think that's pretty good. So even when you have things like 99% accuracy, that means we're still going to have a pretty high misdiagnosis rate. So again, go back to what you said you'd be using this model for. All right, what to do about the F1 score? How do you interpret 0.78 on the F1 score? My best approach to doing this is to try and figure out how you could generate a 0.78 F1 score with one of the input variables being pretty bad or unacceptable. And so the way I did this is I could get to 0.78 of an F1 as an F1 score if I had a sensitivity of only 67%, but a positive predictive value of 100%. You'll get that number. And so you have to sit there and think, well, is a sensitivity of 67% appropriate to how we're going to use this, despite a high positive predictive value? And that's again why I think the Matthews correlation coefficient is probably a better measure of how well a model is functioning. What did everybody else do? Their accuracies ranged from about the same, about 80% to 95%. F1 scores were all kind of on that similar range, approaching 1. Most studies did their validation using a k-fold cross-validation, and the data that I'm showing you is really just the output of those validation studies and not any external data. This means the accuracy was calculated as an average of all the validation iterations. And I actually think if you're going to report the accuracy of a k-fold cross-validation, you should probably give a confidence interval. And none of them really did that. I think that's something to ask for if you're looking at these articles. So, um, I got to move this. So read the methods section in detail on any of these articles. Pay close attention to the class balance, the distribution of cases in the training and validation sets, particularly if the data is reused. Um, Note any upfront transformation or manipulation of data, and at least consider how it might be different from clinical practice. It might be appropriate to do to achieve the results they're looking for. Consider how the ground truth was established, what kind of statistical measures were provided. We went into depth about how to talk about those, and then calculate the number needed to misdiagnose from accuracy. I think that's an important exercise. And then really, really, I would love to see the Matthews correlation coefficient used more often. I think it's much more informative than things like the F1 score, which is more commonly reported. I want to talk, we were criticizing an article out there, but I want to talk about an article from actually a long time ago in PEDS. So this is not pathology. That is probably one of the best, an exemplar article of a machine learning algorithm that was well developed and well tested in the literature. And so this was actually a vital sign monitoring algorithm in the NICU that just spits out a percentage of the chances of this patient, this NICU baby, developing sepsis in the next 24 hours. So they randomized patients to having this little display next to them spitting out that number or not. And the doctors were not double blind to this, which actually wound up being kind of a good thing, I think, as we'll see in a second how this thing was used. It was done over a long period of time, over 6 years, with over 3,000 patients. And that's just the prospective part. That's not the model development part. They looked at outcomes. They looked at how did these patients do. So they looked at the mortality rate and how much increased burden on the hospital's resources having this model displayed. And the reason for that is how did they use this? So the model spits out a percentage chance that the patient's going to develop sepsis in the patients that were randomized to having that model displayed to their doctors. And their doctors were allowed to make decisions after interpreting that data. And I like that because it puts us still in the driver's seat in terms of making decisions about patients. And I think they captured, what are the potential burdens or problems of doing that very well by looking at how much extra lab tests did wind up being ordered in those patients. And there was a small increase in extra lab tests ordered in patients that were randomized to having that monitor. But it led to a significant reduction in mortality rate. And again, I think we should be looking at patient outcomes since that's what we really care about here. One interesting thing is that the model needed to be retrained ward to ward, not just hospital to hospital or institution to institution, but ward to ward. So different floors needed a little recalibration. And I think that to me suggests there has to be something going on, some parameters it's reading that are slightly different. And I just think that's a really interesting thing to how some of these models still probably overfit a little bit. Okay, so why have so few studies repeated this success? I mean, probably it's very hard to do and expensive to do, and it's much easier to generate a model and publish on it. But I have some deep thoughts on this, and so that's what we're gonna talk about in this last portion of my talk here. So I want boring robots, actually. I want something that is as close as possible to a lab test to use. So articles claiming superiority to physician expertise, I think are pure clickbait. I don't think they offer anything interesting or useful to us. Articles demonstrating non-disruptive but beneficial utility, like something that is just another lab test, is really boring, but I like it a lot because I can use it. I could turn around and use it in my practice. Machine learning models, I think overall, are really good at being vaguely right, which we can use. And they're also very good at being precisely wrong, right? Anyone who's maybe played around too much with ChatGPT has probably identified sometimes where it's been very wrong about stuff. And so we need to control for that. But we have the tools for that, right? We run clinical labs. We know how to do this. And then I think you need to ask yourself, and I'm getting very philosophical here, but how do you want to practice medicine, right? And so I have a quote, this is 25 years ago, from a Wendell Berry, who's an ecologist and kind of a philosopher and writer. And he says, it's easy for me to imagine that the next great division of the world will be between people who wish to live as creatures and people who wish to live as machines. And so think about that. in terms of how you want to practice medicine. He also went on to describe kind of what is the mind in this same essay here. And he described it as the sum of all these different parts. And I think maybe we've developed a brain, right? Maybe we have an artificial brain, but these AI algorithms lack all those other components, right? And so my question is, how can something that is less than this be the origin of truth? And I think there's a recent white paper from Apple that suggests that even the most advanced AI algorithms aren't really thinking because they're struggling about the same as more primitive AI algorithms on novel challenges. And so one hypothesis that this group at Apple presented was that maybe they're just really, really good at memorizing and aren't actually critically thinking at all. Um, Lastly, I have a parting shot, and I hope everyone's paying attention here because this is actually kind of important. I could probably give a whole nother talk on this. So, if you search PubMed for the word delve, articles containing the word delve, it looks like this, the output, and you can do this right now. And I think there's an uncanny uptick after the advent of AI, right? We were going maybe a couple hundred articles per year contained the word delve to 3,000 articles in 2024 containing the word delve. And this is not out of proportion with this is the overall increase in number of articles over the years. I don't think this is disproportionate to just that there's more articles out there. And it turns out this is not a coincidence. Words like delve, underscore, and realm are favored words by ChatGPT that us humans don't tend to use too much. And there's been a disproportionate increase in their use over the years. So keep that in mind. Now, anytime I'm reading, I'm on the med school admissions committee. Anytime I'm reading an essay by a prospective medical student, I sit there and I go, oh, did they say delve? I wonder what that means. And so just keep that in mind, especially if you're doing peer review, that this is a real phenomenon out there. And I think it speaks to a complete misuse of generative AI to crank out manuscripts. And so with that note, I'll thank you all for your kind attention and giving me the opportunity to speak. It was really a lot of fun. I like talking about this, and I'll take any questions you have. Although I don't know I'll be able to answer all of them. Uh, Someone's got their hand raised.
Yeah, th thanks, Dr. Seifert. That was really interesting, and I appreciate all the cautionary points you put in. Yeah, I guess we have a question from the audience already, hand raised. If you want to go ahead.
That was a wonderful talk. I'm Ishmael Bazoun, one of the hematopathologists. I just wanted your thoughts about you were talking about machine learning, but there's a problem with the machine learning is that it depends on the data you feed the model, so you're gonna be subjective to algorithmic bias. So how do you actually overcome this? And another question is, what are your thoughts about actually deep learning instead of using machine learning? Because
Yeah, I
that's
kind of
kind of
use
like
those terms interchangeably, right? And rightly or wrongly, I kind of use those terms interchangeably, and I think that's okay. But yeah, so what are the how do you avoid the algorithmic bias? I think the only way you can be sure is to actually test the model prospectively, right? If it can work on out of sample data and show satisfactory results, and I think you have to approach it like you do any other lab test, right? So if I developed a new flow cytometry panel, I would test it prospectively, right? I would validate it. And I think we need to do the same
Mhm.
thing um, with these models to really get a sense for if we're going to use them clinically. I think that's what we need to do. Um, Hope I answered your
Okay,
question. Yeah, yeah.
and how about what are your thoughts? Like, I mean, like when you use an AI model for machine learning, I think if we're using it clinically, it makes more sense to me to use supervised learning rather than unsupervised. Or what do you think
Right. Yeah.
about that?
So, I mean, I think it depends in part on I actually think it depends exclusively on what you're going to use it for, right? If it's going to be something that's going to flag benign and malignant, it might make sense to do something supervised where you have a ground truth label, right? And you have to be careful how you do that, and how you establish the ground truth. I think the things where we see more unsupervised learning are more in the large language models, right? And more in the things that are kind of uh, not spitting out a binary result. But again, I would just go right back to the first question, which is what is the use case for what you're developing? And I think that'll help guide you here.
Thank you.
I've got my
Um,
references here too. Yeah.
yeah, I have like I guess just like an example of from Neuropath, the methylation classifiers are really good at giving you essentially a diagnosis, and in some tumor types like the specific subtype that we can't really determine with IHC or traditional molecular tests. Um, like 8 subtypes of medulloblastoma where we might be able to differentiate it into like one of three using the other tests. But on top of that, you could also put a completely different tumor type. Um, you could run a sample from a completely different tumor, and most likely it would give you the right diagnosis. Um, but I guess there's two. I guess using that same sort of classifier, the same technology, there's two different ways to look at it where your interpretation of its like appropriateness of use and utility would be very different. Where if you're one of the early people in like 2018 saying, "Oh wow, this is so effective, it's going to replace pathologists," then I think the test would be a big failure because of a lot of drawbacks. But then um, if you look at it as another test, it is a very useful test in a lot of cases that ends up being the thing that nails down the diagnosis. So I just because you mentioned like boring tests are what are exciting to you, and so I was just kind of thinking about that's a test that if you interpret it as the end all be all, it's a big failure. But I think it also is maybe you could consider it one of those boring tests, when supervised by an experienced pathologist. I don't know if you have any
Yeah, yeah.
thoughts on
There's
it's not really a
actually
question, I'm
no,
sorry,
it
but
wasn't a question. That's okay. I can still respond. There's something. There's something called the culture shock cycle, and this was described actually decades and decades ago. And I can't remember exactly the author's name, but I can remember the first couple steps. The first step is the honeymoon period, where everyone thinks it's kind of like the hype cycle, where everyone thinks is really great and is going to fix all of our problems, and then a period of frustration follows. We're somewhere in between those, right? There's a lot of folks that I think is going to fix everything, and then there's like, I don't know what I'm doing with this, right? And we don't know what to do. The third step is adaptation, and I actually think we need to get there sooner rather than later to stay up with these things before something happens where, I mean, I'll be honest, so my real fear isn't like that these models become so good they replace us. My real fear is that hospital administrators think that, right? Because if a hospital administrator thinks that, then I become actually irrelevant from a bean counter's perspective, right? So that's really my fear. It's not so much that they actually are able to beat us, which is why I sort of think those articles are pure clickbait. But to go back to your question about about the specific model you were using in Neuropath. I mean, if I had something that in real time, as I'm looking at a flow cytometry case, could say, this is high risk, right? This is high risk for this diagnosis. I think it would make me feel, and that assuming that number was validated prospectively and I had some level of comfort with it, like I do with other lab tests, I think that would be useful to me. That would make me feel more comfortable signing a case out, right? It might actually make me more efficient. Well, those are my thoughts. So I'm not like total. I don't want to sound like I'm a total Luddite on AI or I'm a totally against it. I just think we have to think about it as physicians and how it's going to affect us.
Hey, Bob, this is Andy Nelson. I'm one of the molecular pathologists. I choose to be a total Luddite on technology, even though I'm in molecular. But I think that so. My question is definitely following up just exactly how you're answering Garrett, which is how as physicians, how as pathologists, how do we, I think, philosophically maybe change that narrative, right? Because I've had the same experience too, where I've worked with colleagues who are computational AI, and I don't know why, but they're obsessed with just trying to replace us. Most of them,
Yeah.
like, oh, it's got to be better than what you do, and I'm like, no. And then how do we find collaborations? How do we put out white papers? How do we change that narrative to do exactly what you guys are talking about, which is to say we need to develop these tools to make our practice and the care of patients better and more accurate. And like you said, really what we need are either those adjuncts or those relatively boring tests that provide us important pieces of information that quickly get us on the right track so that ultimately we make better classifications, just like Garrett was describing with the methylation classifiers.
Yeah, I think it involves cutting through the hype, right? And that we may not need to, if the AI bubble bursts, like then maybe we won't need to, but I don't know that it will. Like I can't see the future. So then maybe we won't need to cut through it as much, but I think that's what we need to do. Because I mean, look at it like your thermostat has a machine learning algorithm in it, right? But you don't think of it that way. And that's kind of what we need, right? We kind of need something that's going to help us do our job. So I think in terms of what you could do if you can find people to collaborate with, I would develop things and just think of it exactly like it's another lab test. And I think you'll wind up with something useful at the end if you do it that way because and I say this because it's what we've been doing right in our discipline for so long. And so I think I would disregard the oh it's going to replace us literature except for when maybe you're talking to a hospital administrator or something like that. So, any other questions? This has been a lot of fun. So I enjoy talking. It's really outside my discipline and to some degree, and I just think it's really interesting and fun to talk with you all about.
I see a comment in the chat. Thank you. What was it? A great a great delve into this important topic. It really
Yeah,
underscores the realm of AI.
yeah. I really want to see. There was a thing that said there's going to be an AI transcript of this talk, and I'm really curious to what it looks like. So,
I'm sure it has a favorable view.
yeah.
I I
Can I say something from an anonymous colleague? Maybe we can get AI to replace the hospital administrators.
Oh, hey, there we
I'll
go.
just say
Yeah.
that out here.
Yeah,
I'm
yeah.
willing to jump on that sword.
Oh yeah, no, I'm with you. Sign me up. Yeah, I think
You were trying to keep my anonymity, Andy.
yeah. I think there's
I was not going to throw you
probably
under the
some.
bus, Sophia, but that was fantastic.
Talk about low
Thanks,
complexity, right? I mean, hey.
I mean, it does underscore it. Like I want, and this is why it's so boring. I want AI to answer all of the boring questions I get in email from hospital administrators.
Yeah, yeah.
And like, make that part of my job running, the biomarker care map and all this other stuff, like take 30 minutes a day rather than 3 hours a day. That's what I want the AI to do. But
yeah, I mean, two very anecdotal like use cases for me recently where I used Copilot. I had a long kind of poorly formatted list and I needed it in a nice clean table. And I just said, hey, Copilot, do this. And it did it in like 30 seconds. And that was useful to me because it saved me, 5 minutes of mundane work, right?
Yep.
And then another thing, my dad was seeing a doctor recently, and he put the phone on the table and said, an AI is going to write my note for me. And if you're okay with that, what it means is I'm not sitting there at the computer typing away, not looking at you. And he thought that was, I mean, he actually got to have a conversation with his doctor, which, post electronic health record that's been missing, right?
Yeah. For sure. Lots of cool opportunities like that.
Yeah.
I have one more quick question. What do you think about or I guess do you have thoughts on like breaking down? I feel like a lot of the like what even is AI? I think using the terminology like machine learning is helpful because there's a billion different ways you could use machine learning algorithms, but I feel like the questions have gotten a lot bigger. Like the methylation profile. And just to go back to the example, the question is like make the diagnosis, like which is not something that like most lab tests have been developed to do, right? Like we do a molecular test to look for a specific mutation, or we're doing an immunostain to determine if there's expression of a thing, and then we use that as a tool. And so, like one of the examples that they used with digital image analysis at the NIH was that they were using sort of like a tiered analysis tool where they sort of had a larger question of what is the diagnosis based on whole slide images. But then they broke it down into a bunch of different levels. And so like part of answering this question is like, and it's basically what Dr. Krisak taught me originally about how to look at a frozen section on a brain tumor. Like, is normal or abnormal.
Normal or abnormal.
Is it a tumor
Yeah,
or is it
benign
a
or
non-tumor?
malignant, infectious,
And if it's a
non-infectious.
tumor,
Yeah,
is it
yeah,
glioma? And
yeah,
then
yeah, yeah.
so like it can answer a lot of those questions
You see what that is a
pretty
decision tree,
effectively, and then
right?
it's building
What Dr.
on that.
Krisak does is a decision tree, which has been around for a long time in the world of machine learning, and it's nice because those are transparent, right? You can kind of follow along, and I think we lose our way a little bit, depending on the use case for some of these algorithms. Uh, they're doing all these different things, and they lose their explainability. And I think actually that has a lot to do with what the output is, right? Like you mentioned, the output being um, a diagnosis versus you look at that PEDS article in the NICU, it wasn't saying this patient has sepsis. It was saying they have a higher risk of sepsis than other patients around them. And again, that's like a lab test, right? That's just sort of a thing that you can internalize and use in the context of everything else you know about that patient. Um, a lot of these whole slide imaging studies, they're not getting a history right with that. And maybe for some biopsies that's not important, but I think it probably is. At least we do, right? We look at the history when we look at cases. One thing I should clarify, I didn't do a great job differentiating machine learning and AI in the beginning, and kind of because I think the terms are used more and more interchangeably now, which is probably incorrect. But machine learning is a lot of what I showed. AI is when those algorithms approach what appears to be intelligence to us, right? That's sort of a rough and ready interpretation there. I think there's a couple other questions or comments in the chat. Let me see. Or not. Okay.
Mostly thank yous.
Mostly thank yous. That's very nice. It's been very fun, and thank you for having me. Yeah.
I don't have anything else. I don't know, Amy, if we're good to wrap. Thank you again, Dr.
Hey,
Seifert.
thank you so much. Yeah, yeah.